12, 4 time or 8 time, further 6% reduction is the average when you're increasing the dose of statin. That's very important point to consider. An addition of bempedoic acid to statin azithromycin versus statin titration in patients with high cardiovascular. That's a small group of patients, but at least in a comparison, you can assess that what happens if you add on bempedoic acid to existing treatment groups, how much of reduction you can get with that rather than increasing statin therapy. You can see here that almost like 18% as compared to your 5 to 6%. Total cholesterol, 22%. But this was, remember, this was a small group of patients, like LDL greater than 70 in 120 patients, which were really randomized to bempedoic acid group or increasing the dose of statin. But clear that adding a second drug rather than increasing statin dose, you get much more reduction of your LDL, around 22% reduction of LDL as compared to your 6% reduction with increasing dose of statin. So with that, I conclude here that considering these all things together, now we need to judge our patients whether they are achieving their targets or not. And before that, assess their risk as well, both in atherosclerotic cardiovascular group as well as even in primary prevention group. They may be as high risk as a group of atherosclerotic cardiovascular disease. And now we have different modalities to assess rates: prolonged diabetes, CKD, increased calcium scoring. They all are putting our patient into very high risk of developing future cardiovascular events. Then after assessing these risks, try to get our LDL to the targets, because then you get the maximum benefit out of your treatment. Just giving a statin with an average dose and just following your patient, even without lipid profile or even without cholesterol levels, is not enough to decrease morbidity and mortality of your patient. We see in our daily routine practices कि वो पेशेंट जो 5-10 साल दवाइयाँ छोड़कर आते हैं और फिर उनकी एंजियो की जाए, वो जो थोड़ी बहुत बीमारी होती है वो इस तरह फैल चुकी होती है. सो इट्स नॉट जस्ट अ प्रोपेगेंडा के स्टैटिन, इसके अगेंस्ट बहुत कुछ बना हुआ है. It's LDL levels. You have to take care of LDL levels. If you can get it with your maximum dosages of statin well enough. If you can't, then add on drugs, and especially with high risk of those who can develop statin intolerance, start right from the beginning a combination of 2-3 to get maximum benefit and come closer to your LDL targets to achieve real benefit. Bempedoic acid alone is recommended to achieve target LDL levels along with other non-statin therapies. So now it's very clear enough in the guidelines that you can add on bempedoic acid, included in guideline as an option for patient needing additional LDL lowering with the benefit reducing cardiovascular event when added to statin therapy. With that, I am coming again to those 3 cases with which I started on. So just quickly review them. 45 years male, history of familial dyslipidemia. इस familial dyslipidemia के आपके ख्याल में LDL का टारगेट क्या होना चाहिए? इस वक्त इनका LDL है 235. What should be the target LDL of this patient? Roughly, anyone? 100 तो कम से कम होना चाहिए. ठीक है, अगर इसमें और एडिशनल रिस्क फैक्टर निकल आए तो और नीचे आना चाहिए. नाउ जस्ट कंसिडर, even with maximum dose of statin, can you achieve that target? LDL is 235, 30%, 40% maximum reduction with even maximum dose of statin. Like रोजुवा आप 40 भी दे दें तो इसका आप 40% further reduce कर लें तो कितना लगा सकेंगे? 120, 130. So this is a kind of patient where you need right from the beginning a combination therapy. So moderate dose of statin and a combination of maybe ezetimibe And now we are lucky that we have bempedoic acid as well to achieve these targets. So I personally believe in this is a patient where we should be adding right from the beginning a moderate dose statin, ezetimibe, and bempedoic acid to get maximum benefit out of it without major side effects. Similarly, 60 years smoker, diabetic, hypertensive. So multiple risk factors along with diabetes. Total cholesterol 245, LDL 160. Again, similar kind of situation. Target is 70, LDL 70. And if this patient has an element of CKD, then even less than 45. So even in this patient, right from the beginning, moderate dose of statin or moderate to high dose bempedoic acid and ezetimibe to get your target as early as possible. The third one again, 44 diabetic male, MI 2 month, total cholesterol 260, LDL 170. और यहाँ तो अभी recent event होके गुजरा है, what LDL target you need according to the latest guideline? Less than 40. Less than 40 can't be achieved with statin alone. So certainly that's a group of patients, but you have to identify these group of patients and offer them appropriate therapies right from the beginning to get your target. Here the target is less than 40 and baseline is 170. So again needing